Hello, everybody, and my name's Tim Spector, and welcome to Dr. John Campbell, who's with us today to discuss a controversial topic that's around both in nutrition and in COVID. That I and John, as many of you know, is a YouTube star on this. Everyone's always going on about, have I listened to his video and why don't I change my views? Because he's laid it out so clearly. So I thought this is a great occasion, John, for us to have a chat about vitamin D, because I've obviously been working in the field for about 25 years on and off, and was certainly a big fan of it. But none of us are really experts on vitamin D and COVID. This is all new to everybody. So that's laying the framework. But do you want to kick off and tell me why you think vitamin D is so good and why you take it regularly, and what, what's led you to really start promoting it?
Yeah, thanks for that introduction, Tim, and thanks for having me again. It's great to talk. The reason I started thinking about vitamin D really was that, first of all, it's an unusual sort of nutrient stroke pre-hormone. So the vast majority, or in fact all of the nutrients we get, all of the essential, let's call them vitamins that we need and the minerals that we need, come from our diet. Now, if you eat quite a lot of seal and fish liver and you have basically an Inuit type diet, then you're probably going to get enough vitamin D in that diet. But for most of us, we don't. Perhaps 10% of my vitamin D requirement comes from my diet. We just don't get a lot. So, of course, where vitamin D comes from is from the sun. It's from the sunshine. The skin synthesizes the vitamin D on exposure to ultraviolet B radiation, and then the chemical form there trots off to the liver, and the liver transposes it into another form, and then it trots off to the kidneys. And then it's the kidneys that actually convert it into the most active form. And of course, in the old days, I remember working with renal patients who had quite significant bony demineralization before this vitamin D problem was worked out in patients with kidney failure. So we have it from the sun. And another reason this is so important is when humans first started migrating into Europe, presumably, and I think pretty well most geneticists would agree on this, Tim might comment, but we were dark-skinned. So the original humans were dark-skinned. If we come from Africa and the Middle East, we'd have dark-skinned human beings migrating north. And the only real selective advantage to developing a white skin over presumably a few thousand years of human change and evolution is that the white skin produces vitamin D if you take my skin compared to a dark African skin, I probably make vitamin D, say, 20 times quicker. So that is the big adaptive advantage. Now, why would this be selected in if there wasn't a good reason for it? And then we can combine this with some modern biochemistry. And again, Tim knows much more about this than I do, but my understanding is that certainly there's vitamin D receptors, I believe, in all of the immunological cells, and potentially vitamin D receptors in all cells in the body, some people say. That's my understanding. So there's vitamin D receptors all over the place, which indicates that it's really quite important. And then you take together with the fact that a lot of us wear clothes all the time. We tend to work indoors. I live way up in Carlisle near the Scottish border. And basically, we don't make vitamin D in significant amounts until the sun's about 45 degrees in the sky, which, of course, a lot of the time here it isn't. And then if you take studies from the States and studies from the UK, serum vitamin D, the active form of vitamin D levels, we find that the active form of vitamin D levels are really quite low compared to people who would live in sunnier environments. Whereas people who live in sunnier environments and exposed to the sun have higher levels of vitamin D. So a lot of things kind of came together really to indicate that this is important. And then I started reading some data that shows studies that have been done with people with low levels of vitamin D who are somewhat more prone to influenza, where the studies have been done. And then vitamin D implicated in other forms of immunity. And then that sort of started me thinking about the vitamin D and the COVID. Are we deficient in vitamin D? Is this leading to immunocompromise? And then as the COVID went on, really we learned this about last February or so. It seemed that a lot of the complications of COVID-19 weren't so much occurring in the first week where there was a significant viral phase of the illness, but was more occurring later on when there was an inflammatory stage of the illness and the alveoli were filling up with fluid for inflammatory reasons. And then, of course, we learned that vitamin D is an immunomodulator. So low levels of vitamin D could inhibit immunity, but low levels of vitamin D could also allow inflammation to become somewhat rampant, leading to this now infamous cytokine storm. So that immunomodulatory effect seemed to come together. I mean, I could go on this for quite a while, but the
disagreed with you much so far, but
okay.
I think there's a killer point coming somewhere. You
Yeah.
know, it's called cause or consequence. And, 20 years ago when I was starting out on vitamin D, I believed it was the cure for everything from depression, fibromyalgia, rheumatoid arthritis, osteoporosis, which I was an expert in, and was prescribing it all over the place. And at least 100 diseases have been associated with low vitamin D levels. And because definitely if you're sick and you've got a chronic disease or perhaps a severe acute disease, your levels go down. And so this association was made that this is absolutely crucial, and therefore, and I'm not disagreeing, we need vitamin D, although most people don't call it a vitamin anymore, but it's a sort of steroid. Yeah. Question is, if we've got slightly low levels and we give people more, does it make any difference? To my mind, that's the key thing here. And then as soon as we've gone to randomized trials for these 100 diseases, we basically failed to find any evidence that it works. So the observational studies are both the vitamin D levels and your baseline level and developing a disease are generally all positive, i.e. show a link between the disease and the vitamin D. As soon as you do a randomized controlled trial, you give people dummy vitamin D, other ones, and I've done a couple of these myself ages ago. You don't actually see a difference in bone density or whatever it is. And I think we're going to see the same thing with COVID, and that my view is that everyone loves vitamins. We love a simple solution. I think vitamin D is probably everyone's favorite vitamin, the sunshine vitamin.
Yeah.
You can get it free just by going outside on a nice, spring or summer's day, and 15 minutes you're topped up. It's brilliant. And, so it's got a natural PR company working for it, as well as the billion-dollar industry that also supports it. So I was interested to see if, because I think there's several issues here. One is, what is a normal level of vitamin D? And then, does giving chemical supplements to increase that actually have the same effect as increasing your natural levels anyway? And that's the other whole question that comes in here with supplements is, are they as good as eating the food or having the sunshine? And I think that's really not resolved. And there are definitely some evidence that I've been reading that, broccoli extract, sulforaphane is not as effective as broccoli. Having calcium tablets is probably harmful to you relative to drinking milk or getting the calcium from your vegetables. So they're the issues that that concern me, and there's some other evidence which we can talk about Mendelian randomization. But what are your thoughts on that, cause v consequence, and how good is the data on COVID, for example, with those things in mind? Because I think you've probably read the recent literature more than I have.
Yeah. Just can I ask a question first, Tim, just to clarify my own thinking? I mean, how well documented is it that acute disease results in an acute reduction in vitamin D levels? Because this is not something that's in the medical textbooks. You don't read about particular diseases. And then it says one of the clinical indicators of this is low vitamin D levels. This is not, is this something that's sort of well established in medicine, or where is the state of, when you're reading about, anything, you're reading about sepsis, it will say, well, that goes up and that goes down and that stays the same. We don't see that in the medical literature for vitamin D levels as a biochemical signature or a sign of acute disease, or do we? Correct me.
Well, I think it's partly because vitamin D testing only came in about 20 years ago. Right. When I started my career, it really wasn't possible to get the tests. And then it took about 2 weeks to get a result. So by the time you've worked out whether the patient's getting worse or not, it's all past history. So it's not used like a getting your electrolytes measured, or getting your ESR or your white cell count. So I think it's never been used in the acute setting. So we don't have much data on that. We do know from lots and lots of case control studies that once you've had a chronic disease or an illness, nearly everybody is low compared to the healthy control group. So that it's a non-specific sign. And that's why everyone, with lots of diseases like fibromyalgia or depression would have low vitamin D levels. And everyone thought, well, we've got to treat them. That's going to cure the depression or the muscle pains or whatever it was. And whenever they did the randomized trials, it failed. So it seems to be a common theme that vitamin D levels are changing due to the general state of the body, maybe as an adaptation, maybe because of other proteins sticking to them. We don't know. But I think that's my understanding. There may be some acute studies that I'm unaware of, but it's because you can't get a result quickly. It's not of use to a clinician. I think that's the main reason.
I mean, I've worked recently in A&E, and we don't routinely measure vitamin D levels. And talking to colleagues in intensive care, again, they don't routinely measure this. So I think the contention that acute illness results in a reduction in vitamin D level is one where we probably still need some more evidence, I would think, but it's certainly an interesting one to look at. Two thoughts come to my mind there. People that are acutely ill, firstly, do they tend to spend more time indoors in hospital? Secondly, are people acutely ill more often in wintertime, when, of course, even down there in sunny London, you're not going to be making vitamin D for perhaps 7 or 8 months of the year at the best of times. And the other one that's really intriguing is vitamin D such an important molecule that it's actually used up in acute illness? A bit like using up reserves of energy or reserves of glucose, or of course, I mean, when people are acutely ill, they can lose several kilos of protein when they're acutely ill. So again, I think the cause and effect argument kind of works both ways on that, and it'd be interesting to find some more knowledge on that. But I'm not dodging your question. You are 100% right. There is no firm clinical trial data. Now, there are small scale clinical trials. They're conducted very badly, and that actually brings up another point. Large scale clinical trials that are very well conducted, often conducted in cooperation with big pharmacy companies, produce brilliant papers. The peer reviewers will all love it, and of course they'll get published in the best quality journals. But a lot of the research that's been done around the world on new therapeutics, for example, for COVID, and indeed vitamin D, have often been done at the clinician level. The study in Spain, for example, the Cordova study, there was a small scale study that you know of, and the results from that appeared to be positive. So they did a larger scale study, and the paper was published, and that, as you know, it was later withdrawn because of methodological problems. But that's not surprising, because the methodologies was devised by the clinicians themselves while they're doing another full-time job, rather than being organized. And of course, the problem is vitamin D is a generic molecule. You can't paint it and you can't make money out of. You can make some money out of selling it, but basically you can get it for,
Some people make a lot of money out of selling it, Joe.
Yeah. I get mine from several local supermarket chains. And,
most of it comes from China, I think. Most of the actual vitamin D factories.
And I think there's big questions there on the quality of that as well, which is another issue. But I think there's almost an inbuilt bias in the scientific system that promotes people that can afford to do big scale clinical trials, who stand to make profit out of it, whereas the trials that we say are not so well conducted. Basically because they're not so well conducted, but you'll know clinicians like I do who've funded their own research and done it at weekends. But
those studies, the equivalent would be in respiratory infections, and there was, you probably know, there was a meta-analysis of about 20 small studies of vitamin D. Can it prevent respiratory infections, flu, etc., which people thought was the best, the most closest you could get to COVID, and that was the reason I think a lot of people got excited. And the original one was done on about 12 studies and published, and there's a new one out on MediArchive, which is preprint, where they expanded this list to about 20, and unfortunately the protective effect dropped from about 20% or 25% down to about 11%. And they also said a lot of the studies were very poor quality, and if you took them out, it actually dropped even further. So, we are lacking, I think, an evidence base to really rely on vitamin D. And of course, we've got a paper coming out this week, which I gave you a little look at.
I have the preprint here. Yeah.
Where it wasn't a small study by any means.
No,
we
1.4 million.
1.4 million people who used the Zoe app. So thank you very much if you're listening. Your data was incredibly valuable, whether you were taking a supplement, in this case vitamin D, at the beginning of the pandemic, and whether you got COVID or not later on in the sort of 6 months that followed it. And basically, we found rather hard to interpret results, I think, but I'll ask you in a second. Basically, we found that there was an overall weak benefit, but in terms of slightly reducing the risk of getting COVID, but zero effect in men, and about a 9 or 10% effect in women once you'd adjusted for all the other factors. So there were we thought there were two conclusions. One, it's real, and there is a small effect that only affects the immune systems of women. Or B, that's highly unlikely biologically, and we think it's a selection bias, possibly because women go to the pharmacy and they buy the vitamins for the whole family. But I'd love to hear your take on it, John.
Yeah. I did read that study, and I was absolutely aghast at this difference. Now, we know that there's some differences in the immune system of men versus women, but basically we're both human beings, and to have such a dramatic difference would really surprise me. So I really suspect that difference between the protective effect in women and the non-protective effect in men that was picked up there is not going to be explained by fundamental biological differences between men and women. So interesting study, and I'd be fascinated if it's been peer reviewed. It'd be interesting to see what the peer reviewers say on that. But the idea of collecting data from 1.4 million, though, Tim, is just absolutely marvelous, and this is exactly what we need, this large-scale study. But there is kind of a but on this, even though you've got very large numbers. We have to. You have to ask the right questions to be able to interrogate the data correctly. And I think that question does need answered, the differences between men and women. So that will be interesting. But as well as that, we need to look at it in context of other studies. Now, I'm aware I didn't fully answer your question before. So part of the reason that I really got onto this vitamin D thing, and I personally, I think there's an immunoprotective effect at the moment. That is where I'm currently at, was the Bradford Hill criteria. So I used to inflict Bradford Hill criteria on my students and force them to write essays about it. But the story, Austin Bradford Hill and Richard Doll, of course, discovered the relationship with smoking and lung cancer, and then smoking and heart disease. So Bradford Hill was very aware of the fact that some things are initially picked up as correlations. And of course, chapter 1, verse 1, paragraph 1 of the research manual says correlations are not causality. We know that, but they brought forward things like the strength of the correlation. Now, that does seem to be there with vitamin D to some extent. Now, I know we could argue about vitamin D levels and how likely you are to get the infection, although I think there is some positive evidence there from the British Biobank study indicating a protective effect. But what seems to be the case is that people with the lowest levels of vitamin D, and as you rightly say, Tim, what is the normal level? Who would dare say what the normal level is? But people who had lower levels, in the lower quarter compared to the top quarter, were more likely to become acutely ill, more likely to go to intensive care in some studies. And obviously, a lot of those were observational studies. So you've got kind of a strength of correlation there that people with the very lowest levels of vitamin D are at risk. Now, I think there's a lot of precedent for this. So if you're feeling fine and I give you a lot of vitamin D, like Linus Pauling used to take 8 grams a day, apparently, the Nobel Prize winning, I think, American biochemist, preposterous amounts. And all you do is wee it out, quite honestly, isn't it? So he was taking huge amounts and having no effect at all. But if you have someone who has scurvy and you give them a relatively small amount of vitamin C to bring them up, then that's going to take the symptoms away. And we've got an analogy for this as well. So, for example, you'll know much more about this than me, but the condition we used to call pernicious anemia, I think we now call it autoimmune gastritis, where the stomach is not producing what's called the intrinsic factor. So the extrinsic factor, which is the vitamin B12, can't bind to it. And people end up with vitamin B12 deficiency, which is, again, it's a single nutrient, but if people are deficient of it, giving that basically gets rid of the problem. Or if people have night blindness and we give them vitamin A, or if they have beriberi and we give them vitamin B. And of course, the other one that came out, I remember when this data came out, it must have been late 80s, I think, on folic acid and neural tube defects in pregnancy, where deficiency, again, of a single nutrient. I think rectifying the deficiency in folic acid reduced neural tube defects by about 70%. So we're talking about spina bifida there. So I think
that's all extreme cases, and I'm absolutely agreeing with those examples.
Yeah,
and that really, the whole of nutrition advice and supplements is based on really the scurvy story. You could transform a rabble of crew that were doing nothing and had bleeding gums and were useless into a fighting force, and that's really the story of it. But the question is, if you've got levels that are reasonable, which most people have, 95% of the population have reasonable functioning levels for them, because I don't think we've defined what a normal vitamin D level is. I think there was a lot of hype creating a disease where half the population deficient, and that's just nonsense, because they don't have any sign of it other than this blood level being low. And everyone is different, because we did a genetic study showing that your vitamin D levels are about 50% genetic, and you can actually look at the genes, and they explain 50% of them. We've got worked out about 10% of them, and when you put those into studies to see, like in Biobank, a colleague of mine in Canada, Brent Richards, did this, and his paper, which is in preprint, shows no benefit on COVID in Biobank. So genetic levels, baseline levels, where you are, don't seem to relate to that. And he's used that method to show there's no effect on fractures, and show there might be a positive effect on multiple sclerosis. So it's another tool that we have at our disposal. So I think we can argue all day about what a normal vitamin D level is. And it's largely historical, the way it was calculated, and, as it was titrated with calcium and PTH levels in the blood, which is a bit too technical to go into. But I don't think anyone's really ever correlated those with clinical signs. And my view of the whole immunology thing is, there's been a lot of hype about immune boosters and all this kind of stuff. Yeah, if you've got terrible zinc deficiency and you're 1 in a million people with zinc deficiency, your immune system might be rubbish, because everyone needs tiny amounts of zinc. But do we need extra boosters of zinc for normal people? The answer is no, although it's in a lot of our food supply. So there's an idea that tiny example, that 0.1% of the population that definitely have a problem can be generalized to everyone else. That's where I think the problem is, and that's why we're overselling a lot of these supplements. And for me, the danger is, if you oversell the supplement, you undersell real food and environmental and lifestyle factors to be healthy. And I think that's the danger of embracing all these quick fix supplements. Thinking a vitamin D is going to prevent you getting COVID or getting serious COVID, when actually, the lifestyle, or as we're going to find out soon from our data, your diet quality is probably much more important. So that's my take on this. But do you want to have a final word on this before we?
No, it just raises such interesting questions. So basically, I think what you're saying there, Tim, is your research is showing that there's no such thing as a normal vitamin D level necessarily. That what might be normal and healthy for you, it could be too high or too low for me. So is that
that's right? So you keep finding you've got a low level yourself. I remember on one of your videos.
Yeah.
And you find it really hard to get it higher.
Yeah.
Well, maybe that's because your body's saying, well, I've got quite enough for me, thank you. I don't need any more of this rubbish. For my genes and my body, I'm doing okay, thank you. So I think it makes the whole thing much more complex and personalized.
An individualized homeostatic level. I mean, you mentioned PTH there, which is the parathyroid hormone, of course. And this is all to do with vitamin D and the hormonal regulation of calcium levels. So what I think what you're saying is, although calcium levels are probably going to be quite consistent because it's an electrolyte that's needed for the normal functioning of cells, the same as sodium and potassium. But the regulators that go around that, like the vitamin D, different individuals could potentially need different levels. So it's very hard to say what is a normal for the population. Therefore, it's hard to say that people are high or low. That's an interesting new perspective.
So yeah, what's our consensus? Do you think we can agree? A lot of people, look to us for advice, and
it's pretty frightening, isn't it?
We've come from rather opposite camps, if you like, on this. I presume you're still going to be taking your vitamin D.
I'm still going to be taking it until the sun comes out and I can get my shirt off at the allotment and start making some in my skin, because I just don't get enough. I don't get enough from my diet. But could we agree that people that have very low levels of vitamin D have a suboptimal immune system if their levels are very low?
Yes, if it's extremely low, but those people, I would say, less than 1 in 100. People, not the 50% that the sort of industry claims are deficient and need these sort of treatments.
We need to be so careful about people pushing a particular product on us because they make money of it, and of course the food industry is replete with these kind of examples. I think we could probably agree on this as well, that the immune system is an amazing, mind-blowing, incomprehensible physiological system to me. And if it's working well, if it's working at its optimum physiological levels, I know of no way of boosting that, no way of improving that if it's working at its physiological best. But I do know of several deficiencies, for example, protein deficiency or other deficiencies or other problems which would actually lower the efficiency of the immune system. So I think what we're always trying to do is to optimize the efficiency of the immune system. But once it's optimized, I don't think I know of anything that can boost it beyond that optimum level. Do you?
Well, we don't quite know what the optimum level is. I guess that's the downside.
Okay, right.
So I'm agreeing 95%. The only caveat I would have is I think there's increasing evidence that your gut microbiome quality is probably maybe the number one factor that influences your immune system. So if you get your diet in order and you do all the things that are good for your gut microbiome, you will have the optimum immune system. And then it's getting those three things working together that is the best way, I think, to get your best possible defenses against infections and overreaction, autoimmunity, etc. So we're still in the early stages of fathoming this out, but I think I'd rather we all took a holistic picture on this, but basically with a diverse, healthy diet and trips to the sunshine, I think we can stay as healthy as we can be.
And I'll be getting a trip to the sunshine just as soon as I can in the north of England.